respected chairperson, honorable judges, learned audience, Assalamu alaikum. I am Dr. Mainul Islam, working at NICBD, presenting my case. All essentials are not always safe. My case, Mr. Y, 24 years age, Hindu, hailing from Kustia, normotensive, non-diabetic, a smoker, admitted at NICBD with the complaints of sudden severe central chest pain less than 12 hours. And ECG shows ST elevation B1 to B4, shows thrombolysis was done in CCU, and during thrombolysis there is reperfusion arrhythmia developed which is managed by DC shock. As patient is very young, we work up for young MI, that is with routine investigation, we do some thrombophylite screening like protein C, protein S, antithrombin T, homocysteine level, fibrin level, and ANA. All are normal. And troponin was very high. ECO shows there is LV dilatation with moderate LV dysfunction. In this hospital, coronary angiogram done, which shows 90 to 95% stenosis proximal LAD. We implanted a drug-eluting stent in LAD and discharged with aspirin 75 milligram daily, ticagrelor 90 milligram 12 hourly, atorvastatin 40 milligram daily, bisoprolol 2.5 milligram daily, and remipil 1.25 milligram daily. 1.5 months later, patient presented with, to us with jaundice, with no prodromal symptoms like fever, abdominal pain or vomiting, any itching or pale stool, any neurological complaint or any joint pain. On examination, patient was icteric, pale, no organomegaly, no lymphadenopathy, pulse 100 beat per minute, blood pressure 100 over centimeter mercury. So what is, in our mind, what is the cause of the jaundice? We think it is a drug-induced hepatitis or any viral hepatitis or hemolytic or any congestive jaundice. In hospital, considering all differences, we stopped aspirin, ticagrelor, atorvastatin, remipil, and started clopidogrel 75 milligram daily, maintain fluid, electrolytes, nutrition, and bowel movement. We go for some investigations. CBC show and PVF shows hemoglobin 6.7 gram per deciliter, ESR 40 millimeter in first hour, MCV 106 femtoliter, platelet count 1,36,000 per kilometer. PVF shows polychromasia with multiple spherocytes and nucleate RBC. Reticulocyte count was more than 20%. Serum bilirubin 4.8 milligram per DL. We move predominantly indirect bilirubin. SGPT 87 unit per liter. Alkaline phosphorus 176 unit per liter. Gamma GGT and ultrasonography was almost normal. SBHAG, anti-HCV, anti-HEB, and anti-HEB IgM was negative. LDH was very high. Serum creatinine was 4.5 milligram per DL. So it is a clean-cut case of hemolytic anemia. And then what is the cause of underlying cause of hemolysis? Is inherited in there any inherited cause or any acquired cause? In case of acquired cause, immune or non-immune. In case of non-immune, either microangiopathic hemolytic anemia like HAS TTP or DIC, or in paroxysmal nocturnal hemolytic anemia or any infection. First we go for the Coombs test, both direct and indirect Coombs test was negative, so immune hemolysis excluded. We go for infection screening like urinary blood culture, no growth, serum procalcitonin was negative, and we go for DIC panel, all are almost normal. And we go for flow cytometry for PNH panel was negative, and we go for glucose 6-phosphate dehydrogenase level, and after settle down of hemolysis, which was very low, that is 0.78 unit per gram hemoglobin, normal range 10 to 14 unit per gram hemoglobin. So my final diagnosis is acute hemolytic crisis due to glucose 6-phosphate dehydrogenase deficiency preceded by aspirin with old MI anterior, which is state of post-PCI status to LAD. Deficiency of glucose 6-phosphate dehydrogenase is the most common immunoangiogram deficiency. It affects 400 million people worldwide. Glucose 6-phosphate deficiency is X-linked hemolytic. Acute hemolysis caused by any oxidative stress like some drugs infection. And aspirin is widely used as a part of single or dual antibiotic therapy. ESC recommended 12-month dual antibiotic therapy along with P2Y12 inhibitors. The initiation of aspirin following coronary stent insertion in G6PD deficiency patient has been very controversial. Many Christians have approached this matter with caution. And, there is a lot of case report and article shows the features of hemolysis after starting aspirin, and most of the shows no hemolysis. Here is some literature which shows aspirin cause hemolysis, most of them not hemolysis. So take-home message is low-dose aspirin can cause hemolysis in the glucose 6-phosphate deficient patient. Clinicians should start the use aspirin in this patient group when applicable, but careful monitoring needed. And when there is unexplained anemia or any features of hemolysis, aspirin should be stopped and alternative option should think. Then thank you all for patient sharing.